Good afternoon, everyone. Thanks for joining us. We'll give it a couple of minutes to fill the room here. Good afternoon again, everyone. Thanks for joining us. We'll give it about another minute to fill the room up. Good afternoon again, everyone. We'll give it about 30 more seconds to fill up the room here. Great. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the development of the guidelines on the diagnosis and management of von Willebrand disease. My name is Brett Spatelli, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, March 26. I'd like to introduce our presenters today, Dr. Nathan Connell, Vicki Jacobs-Pratt, and Nikole Scappe. Thank you for taking the time to join us, and I'll now turn it over to you to get us started, Nathan.
Thank you so much for having us today. I'm really excited to talk to everyone about these new guidelines and the ways in which they were developed and how it was developed as a true partnership between patients, clinicians, scientists, and stakeholders. And as we start today's talk, I'm going to just mention that none of us have disclosures related to this talk, financial disclosures related to this talk or to the work that was published. And what I'm going to do is go through a little bit of a background on how the guidelines were developed, ways in which patients were included, and then I'm going to turn it over to Vicki and Nikole so that they can talk a little bit about their own experiences as patients involved in this process. And then I have a few questions we're going to go through with them to talk generally about it, but then we'll have plenty of time for questions from the audience. A lot of our journey begins back in 2007, in which the National Heart, Lung, and Blood Institute of the National Institutes of Health, the NIH, published expert consensus guidelines on von Willebrand disease. This actually had started in 2004 when they convened the panel, and there was consultation with groups such as the American Society of Hematology and other stakeholders. And this was a comprehensive evaluation of published literature through 2006, published a year later. And this really was the standards by which we practiced and managed von Willebrand disease for over a decade. In 2015, the NHF convened a strategic summit on von Willebrand disease. This is available online, and part of this report actually served as the proposal for developing new guidelines. There was a big call to action in this report, specifically that a well-qualified and authoritative organization or consortium of these groups should develop new or updated evidence-based clinical practice guidelines. And it was a lot of serendipity, really, that there were many organizations talking about coming together right around this time. And so it was the right conversation at the right time that really led to what was published in January of this year in Blood Advances as a partnership between the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, and the World Federation of Hemophilia to provide updated guidelines. And these are freely available to anyone in the world who has access to a computer and the internet. When we started out the project and thinking about this collaboration, the first thing that we wanted to do was facilitate clinical decision-making on both how do you diagnose VWD and also manage it to contribute to better health outcomes and improving quality of life and health equity. We wanted to increase access to appropriate diagnostic testing and therapeutic options. We knew that there was still a lot of work to do in the research realm, so we wanted to identify research priorities for groups and funding agencies to focus on in the coming decade. And also guide healthcare providers, patients, payers, and other stakeholders. What should the priority focus areas be in VWD, policy-wise, access to treatment, and standards of care? Now, the guideline development process can take several years, and ours took over 5 years from start to finish. It starts with getting a group together, a guideline panel, and we try to balance expertise amongst disciplines, including hematology, patients, scientists. There were pediatricians and adult physicians on there, as well as obstetricians and gynecologists. There's a close attention paid to minimizing and managing conflicts of interest related both to the scientific components but financial aspects as well. The panels prioritize clinical questions in what we call the PICO format. And this is a very specific terminology. We look at a population of interest, we look at an intervention such as a test or a treatment, compare it to another test or treatment, and look and see what happens, the outcomes. So for instance, one of the clinical questions was around in patients with VWD and severe and frequent bleeds, should routine prophylaxis with concentrate or no prophylaxis be used? We then have a very large team that worked behind the scenes to generate all of the evidence, looking at the research that had been published over the last several decades that could answer this question. And we also layered in the effects of resource use, feasibility, equity, and patient preferences and values to come up with final recommendations that were really the heart of the guideline product. Now, this is a very busy slide on purpose, because this really shows you that the panel sits right at the center of this entire process. They formulate the questions, there's evidence generated, evidence profiles generated from medical literature. All of this is done by a team that is experienced in systematic reviews of medical literature. And they work with the panel to come up with the guidelines and the decisions and to go through and say, what are the things that are high quality evidence, where areas that we could use better research in the future. In order to inform the work, the collaborating organizations worked to do a global survey of patients, caregivers, clinicians, and scientists. And the scoping survey was published in Hemophilia in late 2020, also open access for anybody in the world. And we covered 71 countries across 6 continents with over 600 participants. Amazingly, there were 9,000 comments, 9,500 comments that were submitted as part of this. Half of the participants were patients living with VWD, we also saw a distribution across genders and income levels of the countries. So this was one way in which patients were included in the process to determine what should be the priority questions that we answered. Once the guidelines were in draft form, we posted them for public comment. And as you can see, the diagnosis and management panels both had comments come in from different areas of the globe, with more than 100 people commenting and providing very specific detailed comments about the guidelines, and we incorporated that into our final version that went to publication. When we talk about guidelines, you'll see that there are strong recommendations and conditional recommendations. For strong recommendations, this is the highest recommendation that we can provide, that patients would want this intervention. For clinicians, most individuals should receive this. And for policymakers, this really should be adapted as policy, such as quality measures. Conditional recommendations are often based in an area where there is uncertain evidence in the medical literature. For patients, a conditional recommendation might say many would want the recommendation, but many would not. For clinicians, it really focuses on shared decision making. That is the heart of a conditional recommendation, because there are going to be many people who do not want the treatment or the test that's being offered. And for policymakers, this really requires an understanding of how the stakeholders feel about this and providing input before policy is made. In terms of context, the panels took the perspective of a high resource setting, knowing that the guidelines were going to be used globally. And it was important to understand what the goal of optimal care might be. We knew that many of the tests and treatments would not be available in all areas of the world, but we wanted to set a standard by which many areas could work towards in the future. This would also allow advocacy efforts and policy work to occur. And in guidelines, there is this term called adolopment. It's actually a combination of 3 different terms. How do you adapt the guidelines to your particular organization or setting? How do you adopt them into clinical practice? And where are the areas in which you need to actually think about de novo development, new development of guidelines specific to the needs of your institution or your region? Another important context with this are that patients who were serving as panelists were full voting members. So when things came down to a vote, we all participated equally. All of this was kept confidential, so when we took these photos, we knew that people would not be seeing them for several years. But here is the diagnosis panel that had met in Washington, D.C. to come together and make the recommendations. Here is the management panel. It was a separate group working simultaneously and in conjunction with the other panel. And behind the scenes, there were many people working on synthesizing the evidence and searching literally thousands of articles in order to pull together the data that were needed for the panel. And so what do the guidelines actually cover? There are going to be many sessions in coming weeks talking about more specific aspects of these. But in terms of diagnosis of von Willebrand disease, we looked at the use of bleeding assessment tools in order to suggest who should undergo further testing. We made specific recommendations about the assays used to make the diagnosis. What do you do when somebody's level has gone into the quote unquote normal range as they've gotten older? There was a lot of discussion around what are the actual diagnostic thresholds. There was not agreement prior to this panel what they should be, and so we put out some guidance about where should you set the cutoff in terms of levels. We wanted to make some recommendations around type 1C von Willebrand disease, where there's increased clearance, and also thinking about specific assays and diagnostic thresholds for type 2. In conjunction, the management panel looked for the first time to make recommendations about use of prophylaxis in people living with VWD. What constituted a desmopressin challenge or trial? How did we say that someone is desmopressin responsive? As individuals with VWD are getting older and living longer lives because of advances in available therapies, we have to think about things like blood clots and cardiovascular disease. And what do we do in a situation when somebody may benefit from a short course of a blood thinner or a medication like aspirin because they have a cardiac stent? We wanted to talk a little bit about major and minor surgery and ways in which to manage this. And we also had specific questions about managing heavy menstrual bleeding. How do you do neuraxial anesthesia, for instance, an epidural at the time of labor and delivery? And how do you prevent bleeding after delivery, postpartum hemorrhage? So this is the end point of my slides, and I'm going to turn it over now to Vicki and Nikole to talk a little bit about themselves, introduce themselves, talk about their experiences as panelists, and we'll chat a little bit about how they went through this process in partnership with all of us, and then we'll open up for questions. So at this point, I'll turn it over, and maybe I'll ask Vicki to start and chat a little bit about yourself and your experiences with the guidelines.
Sure. Thank you, Nathan. Some of you may already know me. I've been in the bleeding disorder community for over 20 years now. I was one of the first in the United States to be diagnosed with von Willebrand's disease at Boston Children's Hospital in 1960. And in 1993, I was typed as a type 3. However, I did not use factor until I was 40. So prior to that, I had the multiple nosebleeds and joint bleeds, and was actually told at one time that I'd never be able to walk. So any of you that do know me know that I walk around just fine. Now, I've also been engaged in the community through national initiatives, and I've worked with NEHA and FWGBD and the Hemophilia Alliance of Maine, and from which I retired in 2016. And the next year was contacted by ASH to see if I would be interested in being a panelist on this, and I jumped on it. I enjoy working on things like this, and many people had told me in the past that I should write a book, and now I can tell people that I have had a hand in writing a book. It was interesting to me that when Ash first contacted me, that I was told that I couldn't tell anyone what I was working on until it was actually published. I did tell my husband, because I figured all the telephone calls and conference calls and trips for in-person meetings would get a little bit difficult if he didn't know what I was doing. But I didn't even tell my children until the document was published last year. As I said, we had many phone calls and teleconferences, and what I had expected coming onto the panel was totally different than my experience being on the panel. It was very eye-opening to see what actually goes on behind the scenes and the amount of time that it takes to provide guidelines. It's not just like sitting down one day and writing something out and getting it accomplished. But there was a lot of mutual respect on the panel, and I knew several of the doctors that were on my panel. I was on the diagnosis panel, and we did have some very interesting and highly charged discussions over some of the different points that we had. But it was very interesting to see the mutual respect among all of the ones on the panel. And you saw the pictures and saw how many people were on the panel, and sometimes it's a little bit difficult to get everyone in consensus, but it does. So that's a little bit about me. Nikole?
Thanks, Vicki. You're just bringing back so many memories for me. But hello, everyone. It is a pleasure to be here with Nathan and Vicki today. For those of you who don't know me, my name is Nikole Scappe, and I live in Coraopolis, Pennsylvania. Before I started NHF, I got my bachelor's degree from La Roche University, but I have von Willebrand's disease along with my 4 siblings and my mother. And I was diagnosed at the age of 13, a little bit different than Vicki's story, but my bigger issue whenever I was younger was I had the incorrect treatment. So long story short, when I was younger, I have a lot of swelling in my joints, and the doctors thought that that had to be a growth plate fracture because the swelling was so significant. So they would cast me every single time. So like 16 casts later, fast forward, I ended up eventually getting my diagnosis and getting access to factor and having this amazing normalcy in life. But that's just a little bit about kind of like my diagnosis, if I put it together quickly, and a little bit about my background with the community. I was brought into the community. So my mom was diagnosed, she's a nurse, and she found out about camp in a local chapter, a Western PA. So I was able to kind of go to camp around my age of like 13 and start to meet this community. And then I found out about NHF's program, the National Youth Leadership Institute, and I interned with them. And now I'm officially an employee with NHF. So it's been an amazing journey. I'm advocating just for women with VWD generally. And this opportunity was just in awe. Also, just a little bit about my experience with the opportunity. This all happened pre-COVID. So it was really crazy how this all happened, because we were able to have all the meetings in person, all of the calls. And it also, I was asked to be on this panel before I was staff at NHF. So it was really, I was really scared that I was excited when I got hired at NHF, but I was really afraid that that was going to affect my ability to participate in the guidelines, but it did not. So I was really happy that I was able to continue and be part of this amazing process. But as far as like my experience with the process, I would say at first it was a bit confusing. It was all brand new to me. I had to start like from the beginning to end. As you saw that chart Nathan had, like there are all these steps. So I had to really like familiarize myself with that. I have no research background. So between all those significant resources and training, it was so helpful to get me up to speed, because if you know me, I have lots of questions always, and I won't agree and say I understand if I don't understand. So again, I asked lots of questions, and I felt comfortable doing that and having little sidebars. I'd be like, excuse me, someone, I have a question. I just don't quite understand this, and I don't want to talk about it in front of the entire group, but I will second Vicki's comment about lots of mutual respect. And no, I never felt belittled. I never felt like my opinion didn't count. So with that, that's just a little bit about myself and my experience, and I'll pass it back to Nathan maybe to ask another question.
Yeah. We'll just do this as a nice little fireside chat, and so it sounds like both of you enjoyed your experiences. What did you find particularly challenging? What was the thing along the way? Now that you have hindsight of looking back over the whole process, what do you think was particularly challenging in the process?
Do you want to go first, Vicki?
Sure. For me, I think it was figuring out the 10 important questions that we had to ask and research and resolve, because to my mind, it was like, how can you encompass all of von Willebrand's disease in 10 specific questions? And it was remarkable how that just sort of filtered down into those 10 questions. Nikole?
Thanks, Vicki. So I say this, but for me, keeping the secret was like one of the hardest parts of this. I'm a very vocal, outgoing person. So it was just really tough. Like I didn't tell my family either. I remember being in the room with one of the doctors, Reem, and I was like, what, 4 years in? And she was like, you didn't tell your mom? It's okay. Like you can tell your mom. And I was like, I wasn't allowed. Like I'm the best secret keeper ever, I guess. If you tell me to keep a secret, I guess I will. But I would say, aside from keeping it a secret is a challenge, I think that sometimes the physicians would get into very high level, long-winded discussions on very scientific terms. So sometimes I'd be there and I'd be totally on board with them. And sometimes I'm like Googling and like, wait a minute, okay, I'm back. So sometimes I just had to take a moment to clarify and also accept that I'm not a physician and I don't know everything, and not knowing all of that high level terminology was okay at some points, because I slowly learned like where I could give my input. What else? And I think, well, that was just challenges. That's it for now.
And maybe a little bit in follow-up to that specific issue about these discussions going on. I know that some of the staff with the collaborating organizations would do occasional check-ins with all of the patients to see how things were going and to maybe explain a little bit of the background. And we did that as the chairs too. What did you think about those sessions, and how was it helpful to have a separate kind of discussion from the panels?
I thought it was very helpful because again, I was coming at it from a totally different side. I'd done some research papers and things like that, and this was like totally blew my mind when I got in there. But we did have several sidebar sessions with just the patients where a nice gentleman, the ER doctor,
Eddie.
It was Eddie. Came in and really helped us see through the grade process and try to really get us to pin down on and be comfortable expressing our feelings. Of course, I've never had a problem with that, but I think a lot of people might have. But Nikole?
Yeah, I'd agree with that. Well, I think that, how do I want to say this? I don't know. The thought went out of my head, but I think that those sidebars were very helpful. And also, I like remember Mark Skinner being there as well, and he took some time to like he worked on guidelines and saw their patients, so he really explained their role. Because I'm like, what is my role though? Like I'm really having a hard time. Like I'm here, I'm present, I'm doing all of these things you're asking, but I'm just still not seeing how it can be impactful. So Mark really sat us down and talked through examples. Like Vicki said, Eddie gave us some good examples as well. I feel like at one point, I'm a very visual learner, so I need to see things. And we were talking about false positives and false negatives and true positives and true negatives. And I'm like, guys, I can't see it. I don't get it. And so then they made us these lovely little charts. The next day they were printed out and colored and ready to go. And I was like, oh, I get it. This is so helpful. So whenever Nathan was talking about that, those are just some of the things that the staff went out of their way to do to help us make sure we were totally 100% in understanding.
If it helps at all, we were also very confused as the physicians and the epidemiologists that, even though I do a lot of sensitivity, specificity of tests, true positives, true negatives, false positives, even for me, it was confusing. And having that visual chart all of a sudden allowed us to have a group conversation about certain things and really make it impactful. So on the flip side, from the challenges, and I'll start with Nikole this time, is what was so exciting when you started to hear the group talking about it?
There were lots of exciting parts. I feel like one of the most exciting parts was talking about that global perspective. So the whole time that we did this, I had to continuously remind myself that this is not just for the United States, and the ability that other countries have as far as access to care is limited. So when we go into this, we have to go into it with that mindset. So I think of one example, with the bat question, but I remember the panel, and I asked the question, I'm like, well, excuse me, is there a standard bat? I'm a bleeding assessment tool for anyone who doesn't know what that is. And everybody just kind of put their heads down. And I was like, wrong question, bad question. I don't know. But it just kind of brought up that there aren't all common ones. So there has to be a verified bleeding assessment tool. So I think that was just, I don't know, thinking about the global restrictions and things like that. That was really exciting, and just how that these were going to impact others' lives. And I think I know where Vicki's going to go with this, so I'm going to let her take this in a second. But there was a very heated discussion, and I just remember how we were just as long as patients get care, we're good. I feel not completely, but I'll pass it to you, Vicki, because I feel like you're going to touch on what I'm thinking.
Well, I'm not quite sure what you had in mind, but
okay. Wrong. Who knows? Sorry for sharing.
but we did have some very heated discussions, and but first I want to make sure that everyone that's listening or can see us knows that it was a global initiative, in that the panelists had doctors from all over the world participating in it, as well as patients from all over the world, and that was pretty exciting to have that inclusiveness in there. And I've lost your question, Nathan. What
was the most exciting thing when you heard it or you saw it happening? You're like, this is great. This is.
Oh, okay, yeah. One, Nikole, I don't know if this is the one you're talking about. When we were having the discussion on the levels of diagnosis for von Willebrand's disease, yep. and historically, it had been a 30% cutoff. That you had to, in order to be diagnosed with von Willebrand's disease, you had to have less than 30% von Willebrand's factor. And that had always been an issue with me, not that I have that issue because I'm a type 3, but the type 1s that fall between 30 and 50 and still express on social media that they're bleeding, but they're not getting adequate care because they're not considered to have true von Willebrand's disease. They just have low von Willebrand's factor. And that was a real concern. And in the discussion of that, the doctor said, well, gee, even if they fall between 30 and 50% and they bleed, we still treat them for von Willebrand's disease. And then it's just like, well, move it up to 50 then, and that would give a lot more people access to care.
Yeah, I remember this conversation. That was probably, you're right. It's one of the most heated portions of the conversation about where do you set these cutoffs. And I think there was also some realization in the room because the physicians from outside the United States couldn't understand why we wouldn't just say somebody had low VWF, but treat them as such, because the diagnosis didn't affect access to treatment in some of the countries where they were coming from. Whereas here in the US, if you don't have the diagnosis, the access to the treatment, the access to the HTC isn't as guaranteed. So this brings up a good point about the differences between what clinicians and scientists may think of a particular question or recommendation versus the patients. And what do you feel are the value, what's the value of including patients in the discussion for a guideline like this? Vicki?
Well, I think it's really important because we're looking at it from a totally different angle than a clinician. I mean, we live with it every day, and it's particularly in the bleeding disorder community, which is a very tight group. You hear a lot of discussions about a lot of different things, and that might not be brought to a clinician's attention. Whereas a patient can say, now, wait a minute, this is really important out there.
Nikole, what?
Too, as well, Vicki. And I want to go back to one thing. So whenever we were in the room, I can't remember which meeting it was, but that doctor that Vicki was talking about, the emergency doctor, he gave an example of how, I can't remember what the guidelines were for. It was something with seizures. But he talked about the value in the patient's preference. And he was talking about how they were going around for these specific guidelines and they were voting on one particular treatment for a patient, and for the person that had the seizure, the treatment was it was distributed rectally. So the patient perspective, the patients did not want that at all, but the doctors were all for it because that was going to help the patient. So it that example just really made me understand that patient preference when it comes down to it, because a doctor, that's your job. You have no problem helping somebody when they need the help. If that's where it has to go, that's where it has to go. But the patient, if their preference is not that, so that's just how that helped me learn that a little bit. But I would 100% all day saying patients' personal preferences and perspectives also that the physicians might not have thought of as well. And that's really it.
Yeah, it's great because I think this is the first time that patients were included in the guideline panels in such a meaningful way as full voting members, which is one of the unique aspects. You mentioned the confidentiality and not telling people, and then Vicki had just mentioned, things that you hear about on social media. And so as the guidelines were being developed, of course, there were a lot of confidentiality policies in place. But how did you balance bringing in this information that you may have been hearing from the community, especially as they learned the guidelines were being developed? You couldn't say anything, but how would you bring the perspective in from other patients into the discussion?
Okay. Well, for me, it was relatively easy because, like I said, I retired in 2016. So if somebody, and I signed on board on this in early 2017, so it was only a few months difference between that point. So I could just say, well, I'm taking a step back for a while. I'll lurk on social media, and so I really didn't see a lot of people in the community while I was working this process. But if anyone ever asked me, my HTC, what are you doing now? Huh? What are you doing? I just, I'm just, taking some time and learning how to be retired, and sitting back and watching what things happen. And if there was discussion about any guidelines on social media, I would say, yeah, I've heard that too. Nikole?
So slick, Becky. Well, I am quite a bit more involved in the community in my current role. So I had to play dumb a lot. It was really frustrating. And some of my fellow community members would be like, you haven't done anything for VWD in a while. Like, did you just drop off? And I was like, oh, I'm just, getting used to my new job. I'm getting settled with this and that, but I'm definitely going to be back. And, so I kind of just had to play dumb. And I did an interview on Bloodstream Media, and they asked me something like what medical something is going to come out this year that I'm most excited about. And I was like, those VWD guidelines, I heard they're good. I heard good things are coming out on them. And I just can't wait for them to help other patients in the world with VWD. So I would really just honestly play dumb and be like, oh yeah, I'm going to get back involved in a little bit. But, so that's kind of what I did.
Yeah, I think it's important also for people to know that the reason that we had such strict confidentiality and conflict of interest management was because we wanted the guidelines to be guided by evidence. And, there's a lot of ways in which undue influence can be exerted into a process like this. It's a long process. There's a lot of judgments that go into it. And we wanted to make sure that the panelists could make those decisions free of influence from other individuals. And so as soon as the panels were revealed, I and many others started noticing we were getting emails and phone calls from people wanting to, suggest certain things in certain directions. And we wanted to do this without putting ourselves or the patients on the panels into a situation where they would have to, be considered in this way. I'm going to finish this off. This is going to be my last question to you guys. And then I hope that people are putting questions in and we'll be going through those. But what advice would you give to patients who were asked to participate in a guideline panel in the future of any sort?
You want me to go first, Vicki? Okay. I'd say do it. First of all, I think that it might be challenging at points, but after all the work and effort that goes into it, it's something that you can be really proud of and that patients don't really ever get to see. I just think it was such an incredible experience that I don't know if I'll ever get an opportunity to do again. So if you have that opportunity, do it and ask questions, ask lots of questions, utilize the resources around you. I can't tell you how grateful I am for all the people that are like, do you have any questions or do you need anything? I'm like, actually, I do need something. So when people ask you if you need that help, take advantage of it if you're able to do it. So with that, Vicki, what were you going to say?
Well, I was going to say pretty much the same thing. That anytime you get a chance to do any kind of guideline prep or work on getting the word out about von Willebrand's disease out into the community, that's a good thing, as well as one of the interesting points of the diagnosis and management papers is the need for future research and future research projects. And I've been a guinea pig my whole life in the bleeding disorder community, and so it doesn't take up a whole lot of your time to get involved in a panel discussion and work on a panel, and I would say do it.
Anyway, and I'll ask Brett to come back in, and if we've got any questions, we can start taking them from the audience, or we can keep chatting. I've spent years with Nikole and Vicki, so we can chat about these guidelines and VWD all day long.
I think I could say I know Nikole enough to where she can probably talk about this for quite some time, which is her level of excitement's been incredible. But we do have questions that have come in from the audience here, so I will start with this one. What is the most unexpected outcome from publishing the guidelines from each of your perspectives?
You say that again?
Yep. What is the most unexpected outcome from publishing the guidelines from each of your perspectives?
Okay, maybe I'll start.
Yeah.
From a clinical perspective, as a physician, I would say that the thing that surprised me the most. Now, I knew that the bleeding disorders community was active and engaged, but I wasn't completely prepared for the overwhelming support and response that we got to the scoping survey. 9,000 comments. We were expecting, maybe a couple hundred responses total. And most people fill out a survey, they click the buttons, but they never fill out the discrete comment sections. 9,000 comments that we then went through and pulled themes from. And then when it came time to ask for comments, we got, hundreds of comments back on specific aspects of the guidelines. And so that to me was a sign that these guidelines were needed, but we have so much more work to do. And we were setting research priorities and talking about this and putting it out there, but it really has, groups have picked up and run with it. I know that NHF is looking into how do we set a research agenda around these guidelines and what the gaps in the knowledge are. And now we're hearing about NIH funding and interest from the NIH in different aspects of the guidelines and where we go from here. So that to me was very unexpected from a clinical and research standpoint. Vicki, Nikole?
I can go from a personal standpoint, I guess. It's my answer doesn't sound, yours was so lovely, Nathan, but for me, I was honestly really surprised with all the thank yous I've been getting and how grateful folks have been to me. I really don't feel like I'm grateful for it, but I feel like I don't know. I'm just pretty, I just need to do what I need to do to help my community, and I'm happy to help service them. So I was just really grateful for the opportunity, and I'm grateful for folks to recognize that it took quite a few years and a lot of questions and learning to be able to do this. And so I think, it's not the best answer, but as far as unexpected, I didn't expect people to be grateful towards me and make it a point to reach out, and to say good job. And even on social, some of the doctors are we're all connecting and sharing this, and it's just kind of cool to be able to say that we work together as a team. So Vicki, I'll pass it to you.
Well, I think one of the unexpected outcomes that I have seen on both the management and the diagnosis papers is the need for more research and the realization that we have quite a few studies going back decades, but they're not as cohesive as we need them to be, so that we can make strong recommendations on every single point that we brought out. So it wasn't necessarily an unexpected outcome, but I think it did bring a lot more research priorities out than I had expected to see.
Great. Next question comes in, Nathan. This might be for you. How were the panelists chosen?
It's a great question. So the panels, putting together a group of 15 to 20 people times 2 sets, as you can imagine, is a little bit like a game of Jenga. And so there's a lot of moving parts. And so the panels were put together in a very systematic way with attention to a few specific details that I'll outline. So first is that we knew that for guideline panels, we were going to need clinicians, patients, scientists. We knew that we would need people who take care of adults and people who take care of pediatrics. We knew that hematologists did not have the monopoly on diagnosis and management of VWD, so we needed to pull internists in, the pediatricians, obstetrics and gynecology, think about emergency medicine, think about dentists. And so we were very lucky in that one of the methodologists for our systematic review team is also a dentist. And so she was able to provide information to the teams a lot of the time about, what actually is the extent, what's the bleeding risk around wisdom tooth extraction? How many teeth, where does the risk change? So there was that kind of broad experience. Each of the collaborating organizations was asked to nominate individuals. And so there were many, many nominations that came in across the board from all the organizations to try to put together and have as broad a population to choose from. And then there was, as with anything else, a bit of a vetting process. So in order to create guidelines managing conflicts of interest, there's some rules that we followed. For instance, that greater than 50% of the panelists had to be free from financial conflicts of interest. So you couldn't work for a pharmaceutical company that makes a product that treats VWD and have people who were, have that be the majority of your panel. The chairs, the co-chairs, myself, Paula James, and Veronica Flood, who served as the clinical co-chairs, we could not have any direct conflicts of interest with industry in relation to the guideline panels. And then it was also thinking about trying to, from a patient perspective, balance the patients that we had, not just men and women, but also thinking about types of VWD. And so we wanted to make sure that there were some patients who had type 1, patients who had type 2, patients who had type 3 VWD, or they were parents and caregivers of individuals. So a lot of this went into it. And as you can imagine, it's a tough decision to come together. There were people picked, there were lists of alternates. And so we came together as this group that really, after a lot of hard work, finally it was able to sit down for the first time as a group and recognize the diversity of the interests and backgrounds that were represented.
Great. Great. Thank you, Dr. Connell. Appreciate that. Next question comes in. As patients, what do you feel is the most important thing about the guidelines that others with VWD should know? Vicki, Nikole, you guys want to tackle that one?
Yeah, well, I was trying to pick out one, and I don't think I can. I think they're all extremely important points. I think for me, not personally, but being a community member, it's the recognition that people bleed under 50% as well, and that those folks needed to be recognized. Nikole?
Yeah, I think I'm going to go with that as well, Vicki, just because I am one of those people. So it really does make a big difference. And, for anybody, if their levels were testing away, but they're bleeding, like now they're going to be able to have that access to the care they need. And that's the biggest accomplishment to me at the end of the day, that the patient is getting the access to the care that they need. I don't know, like guys, it's hard. I have like all of these, I have all of them printed out, and I'm like, which one am I going to pick? I feel like I'm going to be asked this question. And I was like, between that one and then like about like removing a diagnosis as you age, because of my mother, so my mother's levels are doing that currently as she ages, but she still bleeds. So it also like had a personal connection to me. So I could go into almost everyone and give you like a reason why they're all amazing. So I'm sorry I can't give you a better like 1 point answer, but those are a couple of my thoughts.
Yeah, and I'm going to interject here, and Nathan didn't show it on his slides, but in the document, there's a wonderful flow chart on the appropriate diagnosis. And like I said, I worked on the diagnosis panel, so I'm not as familiar with the management side, but I was really thrilled that flow chart was developed, because it really does show the steps that a clinician needs to accurately diagnose.
Mm-hmm.
That's a good point too, Vicki. I'm glad you said that.
Great. Another question comes in. This is a great question. And then Nikole, I'm going to put you on the spot and start with you on this one. But how do you feel patient advocacy organizations like NHF can best use the guidelines to grow awareness, diagnosis, and treatment for people with VWD?
That's a great question. And I think right away, I just think that we have to dissect them, and we have to make them more consumer friendly and teach people how they apply to them. So like if you look at this giant document with hundreds of pages in it, like that might not really resonate with some folks who don't have a big medical background. So I think what other organizations can do is really create some tools and guides and even videos to help simplify what these are, so people can understand how they can best use them. Like how can you use them with your OBGYN? How can you use them with an orthodontist if they have to plot your wisdom teeth, like the ER doctors? How can you use them in all these different ways? And I think that we can create, well, not volunteering NHF yet. We're working on all kinds of stuff, but I think that all these organizations as a whole can work together and create some really friendly, consumer-friendly materials so that people can actually understand these and know how to use them for their benefit.
Vicki, any take on that?
Yeah, I've been a real advocate for the last probably 15 years on educating the general practitioner and the family practice doctor, and would love to see more outreach into those areas and really get them to recognize the guidelines and be comfortable using the bleeding assessment tools so that they can refer patients suspicious of VWD or any other bleeding disorder that's out there to get accurate, adequate diagnosis and be able to, follow the management guidelines for treatment, because there's so many still out there that are undiagnosed.
Great. Very true. Very true. There are a couple more questions here. Dr. Connell, these ones are geared towards you. What do you feel the patients added to the guideline process, how they made the process or the end product better?
It's a fantastic question. I think that part of it was recognizing in our discussions in the room that people that would be affected by the decisions we were making were in the room. And so there's a lot of worry about people make decisions far away from the consequences of their decisions. That happens in government. It happens, all the time around the world and in different scenarios. Ruth Bader Ginsburg was notorious for saying, women deserve to be at the table for all decisions that are affecting them. And I think that was really true here, that, we had individuals participating in the discussion that were keeping us honest and making sure that we were not making decisions that would benefit the clinicians alone, that it was really for our patients, the people that we love to take care of in our clinics. There were some interesting aspects in the whole process that came about because of this. So very early on, we made a decision that we would go by first name for all of the panel meetings and discussions. This way, there was never a hierarchy. We didn't want to create a hierarchy of Dr. So-and-so is referred to by their last name, and then the patients ended up being referred to by their first names. Some of the patient panelists actually were scientists, had PhDs, and so it's like we wanted to make sure that everybody felt comfortable with everybody else. And that, I think, was really one of the great aspects to this, hearing the stories of how somebody was personally affected by it really moved the needle. There was the heated discussion, like Nikole was mentioning, around where do you set the diagnostic cutoffs. And for people that are saying scientifically, from looking at genetic testing and genetic mutations, you should move the cutoff lower to meet the genetics. But that doesn't treat the person at the end of the day. And hearing over and over again, we need to ensure access to treatment. There needs to be treatment for all people who are bleeding. We need to think about how to incorporate that. There was a lot of push. And I think we delayed some decisions from one day to the next in the panels so that we could think and mull over this and get together in groups. And so I think those are just some of the ways in which the patients made us better guideline panels because of their participation.
Great. I think we've got time for another question here. And this, again, Dr. Connell, is for you, and sort of along those same lines, maybe a tad bit different. As a healthcare provider, what did you learn from panelists through this process that may have been different than just seeing patients in a clinic?
Again, having the patients there to tell their stories, I think, was important. But of course, as a clinician, I hear stories all day. I'm in the clinic and hearing how somebody's doing and walking alongside them in their experiences as much as I can. But one of the things that was really great for me was to hear where we needed to challenge my own practices. If I'm just in one center and one group and not really hearing about how somebody would treat an exact situation, we were all posed a clinical question and said, how would you treat this patient? And so it was interesting to see all the different opinions around the room. And for me to look at somebody who I knew was an expert in the field, has, decades of experience, and they say, I would do this most of the time, but in this specific scenario, I would change it this way. It allows me to come back to my own clinic and say, well, maybe I should be doing this. I really started to push for the 4-hour post-desmopressin check to make sure that I'm not missing type 1C von Willebrand disease. That's not something that I was taught about in fellowship. And it really is my time here on the panels that's really challenged a lot of it and say, back up what you're doing with evidence. And I think that's the biggest change for me.
That's great. What an insightful answer. One last question I think we have time for here, if you don't mind. As patients, what did you learn about VWD that maybe you didn't know before this process? Vicki or Nikole, you guys want to take that one on?
Yeah, I can start. One of the things I didn't realize was how different we were country to country. And all across the world on diagnosing and managing von Willebrand's disease, and that was something that was really brought home because I hadn't really thought about it. I just figured that everybody was treated the same, and they're not. So with these guidelines, there'll be a lot more. I don't know if it's simplification, but at least the guidelines will bring everybody a little bit closer in how they diagnose and manage.
Cool.
Brett, can you do me a favor and just repeat that question one more time? I was so into Vicki's answer that it just out of my head.
You bet I can. As patients, what did you learn about VWD that maybe you didn't know before this process started?
Thank you, Brett. I think what I really didn't know is the intensity that comes with labs in testing. Like I didn't understand, like, so for example, like Paula's lab is very different than like Nathan's or whoever else is on the panel, but like how they do labs and draw blood and all the work they do is very different in other countries. Like how Vicki was talking about, it's different everywhere. And about just like the amount of time that goes into processing the blood. And if it doesn't get processed in that time, then it's ruined. And so there's just so many, there are so many little things that I learned, along with like how people diagnose subtypes, how folks treat differently based on different countries. So like, I won't say any names, but like a doctor in one country, like I just had a personal talk with them, and like the way they would treat is very differently than how my hematologist would treat in the US. So it was very cool to like hear different perspectives on how there's just different ways to treat people, and not one way works for everybody. So that was kind of a long-winded answer, but those are a couple of the new things I learned.
Oh, that's great. That's great. I don't see any more questions that have come in, so I'd like to thank each and every one of you for joining us this afternoon. We appreciate your time and your perspective and your expertise. And I'd also like to thank each and every one of you out there for joining us this afternoon. Please note that this recorded webinar will be available on Friday, March 26th at hemophilia.org under the events tab with all of our archive webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinars. Thank you all once again very much. We appreciate your time and have a wonderful afternoon.
Thank you for having me.
Thank you.
Mm-hmm.
Bye.
Bye, guys.